Hello, my name is Dana Anderson, and on behalf of the National Pancreas Foundation, I'm very happy to welcome you to this webinar, the first of a series of webinars devoted to the type of diabetes that's a consequence of pancreatic disease. The National Pancreas Foundation, as you may know, was founded 26 years ago, and it's the only nonprofit foundation which is dedicated to patients who are suffering from all forms of pancreatic disease, including pediatric pancreatitis, acute pancreatitis, chronic pancreatitis, and pancreatic cancer. This webinar is the product of a working group that was established by the National Pancreas Foundation in order to provide education and service to patients and their caregivers who are suffering from the form of diabetes that occurs as a consequence of pancreatic disease. And in this first webinar, we'll review just some of the basic information that will enable you to be better educated about these forms of diabetes. The moderator for tonight's webinar is Dr. Fred Toledo, who's professor of medicine and professor of clinical and translational science in the Division of Endocrinology, Diabetes, and Metabolism at the University of Pittsburgh. Dr. Toledo, please go ahead.
Thank you, Dana. I would like to thank the National Pancreas Foundation for putting together this webinar, which I think will be terrific and very exciting. Let me start by providing a quick overview of the talks tonight. We have two excellent speakers with us today, Dr. Melena Bellin and Dr. Goodarzi. And we will start with Dr. Melena Bellin, but first, just some housekeeping items. We're going to have the first talk by Melena and then a little question and answer session after that. And then we'll move to Dr. Goodarzi and then another session of question and answers. And that will be followed by another part of this webinar with Dr. Brooke Palmer, who will introduce later too. And we'll ask that everyone puts the questions in the Q&A section of Zoom. So let's start with Dr. Bellin's talk first. So Dr. Melena Bellin is a professor of pediatric endocrinology and diabetes at the University of Minnesota. She's also the director of research for islet autotransplantation. She specializes in treating pediatric patients with diabetes, especially those who undergo total pancreatectomy and islet autotransplantation, a procedure that removes the pancreas and transplant the insulin-producing cells back into the patient so that they don't develop diabetes. She has over 21 years of experience in this field and has been the recipient of several prestigious awards for medical research to improve children's health. Melena?
All right, thank you, Fred, and thank you to the audience and everyone who's tuning in tonight. Fred, please just shout out if you have see any technical issues here or have any trouble seeing my slides. This is going to be really an introductory talk here to diabetes. I realize that those of you joining us on this webinar may come in with various states of knowledge about diabetes, but we didn't want to presume starting these webinars that people would be familiar with diabetes, and wanted to really start from the beginning and just talk about what is diabetes and what are different types of diabetes, and then specifically, why are those individuals who have pancreatitis, acute or recurrent acute or chronic pancreatitis, why are they at risk for developing diabetes? So, let me get my slides forward here. So I'll talk first about just what diabetes is, types of diabetes, how often people with pancreatitis get diabetes. And then there was a question posed to me about, is diabetes from pancreatitis different in kids versus adults? So I'll touch on that. Just a little bit about terminology, and I'll circle back to this. You'll see here some various terms for pancreatitis-related diabetes. Sometimes this is considered part of a category that's referred to by patients and some providers as type 3C. But I will say it gets a little confusing because there isn't a real agreed upon terminology here. And I'll circle back to why we use or sometimes use type 3C. There are some things I'm not going to cover here, and it's not because they're not important, but our next speaker, Dr. Goodarzi, is going to get a little bit more specifically into what are the screening recommendations for someone who has pancreatitis, and what about health implications of having pancreatitis and diabetes together. So just a little 101 about the pancreas anatomy. The pancreas has two really important functions. So there is a exocrine component to the pancreas that really makes up the bulk of the pancreas. So 98% of the pancreas typically is exocrine tissue that has what we call acinar cells that make digestive juices and the ducts that secrete the digestive juices. And the role of the exocrine pancreas is to secrete those digestive juices like trypsin and lipase into the gut to digest fat and protein in response to a meal. This is the part that is affected by pancreatitis. So when patients get pancreatitis, this is inflammation and or scarring that's occurring in that exocrine component. But very importantly, about 2% of the pancreas is islet tissue or the endocrine tissue of the pancreas. And when we talk about islets, sometimes you'll hear people say islet cell, but really islets are a cluster of a bunch of cells, and islets can be small or they can be large. So the number of cells varies by the size of the islet, but say on average, you might have a cluster of about 1,000 cells. And some of those cells are the beta cells that make insulin. And then there's some other cell types in there, including alpha cells that make glucagon to raise a low blood sugar. So insulin being the really important hormone for diabetes that keeps your blood sugar normal, helps your muscles and your fat cells take up glucose for or sugar for fuel. And then the alpha cells making glucagon. And then a cell type we don't talk a lot about, but it may be relevant to pancreatitis, are these PP cells that make pancreatic polypeptide, which might be a marker that we can use to distinguish diabetes from pancreatitis from other forms of diabetes. So this islet part and the exocrine part kind of work together, because when you have a meal, you have the exocrine tissue that is secreting digestive juices into your gut for digestion, but at the same time, the carbohydrate from that food is hitting your bloodstream and stimulating the islet cells to release insulin into the bloodstream to help you use the fuel from your food. So they're really working together to balance your use of that fuel and your energy balance in the body. So when we talk about diabetes, regardless of what form of diabetes it is, there's a fairly uniform consensus on how clinical diabetes is diagnosed, and that's criteria that's established by the American Diabetes Association. And so most people, if they're getting screening for diabetes, may get a fasting blood sugar or fasting glucose drawn in lab, and a hemoglobin A1C level, which doesn't need to be fasting. So the fasting glucose is really what is your glucose at that point in time when it's being drawn. And the hemoglobin A1C is this 3-month marker of average blood sugar, essentially telling us how much sugar is on the red blood cells in your circulation as a marker of what your average blood sugar has been. And diabetes range is considered a fasting blood glucose of 126 or greater, a hemoglobin A1C level of 6.5% or more. And sometimes people will have an oral glucose tolerance test done. This is a really common test during pregnancy, but it will sometimes be done also to screen for other forms of diabetes in clinic. And if you have a 2-hour oral glucose tolerance test and you drink the 75-gram glucola or sugar beverage, a glucose at 2 hours over greater than or equal to 200 is diabetes range. And we want to be really precise and accurate in making this diagnosis. So we typically will require that 2 tests or 2 values are positive to confirm the diagnosis. So that might be someone comes in and both their fasting glucose and A1C are diabetes range, or they have different tests or the same test done on different days to confirm the test result. There is an exception to this for people who have maybe more advanced diabetes at presentation. If they have symptoms of diabetes and a random blood glucose is above 200, that's sufficient in and of itself to just establish the diagnosis of diabetes without doing further testing. I won't get too much into symptoms of diabetes here because it's going to be a topic in the next talk. Now, sometimes you'll hear people talk about pre-diabetes, which is really an indicator of people who might be at risk for progressing to diabetes. It's particularly used a lot for assessing people who might be at risk for type 2 diabetes. And so these are test results that are borderline but don't quite fit the diabetes range. So fasting glucose of 100 to 125, or a 2-hour glucose of 140 to 199, or an A1C level of 5.7 to 6.4. So what are the different forms of diabetes? Well, the ones you hear a lot about, and I'll explain just very briefly what they are in the next slide, is type 1 and type 2 diabetes. But they don't account for all of the diabetes. And obviously, what doesn't fit well in type 1 or type 2 is diabetes that's related to exocrine disease, including pancreatitis. And so this is actually a table that comes out of the American Diabetes Association guidelines on classification of diabetes. And the third bullet point on their table is specific types of diabetes due to other causes. And under this other causes or secondary diabetes, that's where pancreatitis related diabetes fits, and diabetes that's related to other exocrine pancreas disease. Just as a little historical note here, in the older tables about a decade ago, not currently, this exocrine pancreas disease category was on the table under number 3 and then letter C. And so this sort of led to the adoption of the term type 3C. It really isn't an officially recognized medical terminology. It's very, very widely used. But it can lead to some confusion amongst patients and providers and in communication between patients and providers because there isn't an agreed upon term for diabetes that's related to pancreatitis. And then obviously a little bit separately, there's gestational diabetes. So I think if you go out in the world and you're talking about diabetes, people usually think probably first of type 2 diabetes and then sometimes of type 1 diabetes. And in fact, if you look at diabetes in the population, like the US population, the majority of patients do have type 2 diabetes. And type 1 diabetes is more rare, but probably equally prevalent to diabetes of the exocrine pancreas, which gets recognized much less often. So type 1 diabetes is essentially an autoimmune disease. It's a disease in which the immune system gets confused, attacks the beta cells or the insulin producing cells of the islets, and eventually destroys all of those insulin producing cells. So people with type 1 diabetes pretty quickly become completely or nearly completely deficient in insulin, and they're completely dependent on taking insulin shots or wearing an insulin pump. If they don't take insulin, they will get sick quite quickly. They're at risk for a condition called diabetic ketoacidosis. This is a little bit different than type 2 diabetes. People with type 2 diabetes also don't make enough insulin, but part of the problem is that their body is more resistant to insulin, or what I'll tell patients is their body just doesn't listen as well to insulin. So they have to make more of that insulin signal to get the right effect, and their pancreas can't keep up. Their pancreas can't make enough insulin to meet the body's needs. These patients are sometimes on insulin injections, but they might also be on other medications, oral medications, or other injections to control diabetes and blood sugars. So I'm not going to talk much more about these conditions, but I do want to make the point that people who have pancreatitis can still get type 1 or type 2. Type 1 is a little bit easier for us to distinguish diagnostically because we have specific blood markers of autoimmunity that can tell us this is an autoimmune disease. It can be a little bit harder to distinguish type 2 diabetes from diabetes that's caused by pancreatitis. But I do think it's important to know that just because you have pancreatitis doesn't mean you can't also have a different form of diabetes. But usually when we're thinking of people with pancreatitis, we're thinking about diabetes as a long-term complication of the pancreatitis itself. And what happens is people get recurrent bouts of inflammation, and particularly with chronic pancreatitis, they get scarring or fibrosis throughout their pancreas. And this leads to the pancreas not functioning as well over time. and leading to a very high lifelong risk of diabetes, as well as digestive insufficiency, exocrine pancreatic insufficiency. And this risk probably goes up the longer someone has disease. If you look at adults in the US who have chronic pancreatitis, at least probably about 1 out of every 3 or slightly more than that will have diabetes. But for conditions like hereditary pancreatitis, the lifelong risk for diabetes may be as high as 70–75%. So there's a lot of terminology, again, that you'll hear for this condition. Unfortunately, this is a place where we need to maybe come to a little bit more of a consensus on what we want to call this, but you may hear this referred to as type 3C diabetes, pancreatogenic diabetes, pancreatic diabetes. That can refer to a number of different exocrine diseases that cause diabetes, or you may hear to more specifically as post-pancreatitis diabetes, diabetes related to acute pancreatitis, diabetes related to chronic pancreatitis. So why do people not know about type 3C diabetes or post-pancreatitis diabetes? We have a tendency to not always indicate this very well in the medical record. So there's diagnostic coding for secondary forms of diabetes, but there's no specific diagnostic code, at least right now, for diabetes that is related to pancreatitis or related to exocrine disease. Sometimes chronic pancreatitis can be difficult to diagnose. So someone might get diagnosed with diabetes and it's their chronic pancreatitis that goes unrecognized. So they don't get diagnosed appropriately as having diabetes related to their pancreatitis per se. There is an under recognition of pancreatitis related diabetes as being distinct from type 2 or type 1. We're really, with the National Pancreas Foundation's help, working on this, but really there's no endorsed medical guidelines for diagnosing or distinguishing this condition. And there's certainly overlap in diabetes types. So we do know that for people with pancreatitis, much like people with type 2 diabetes, if you're obese, if you have a positive family history for diabetes, that's associated with a higher risk of going on to get diabetes and chronic pancreatitis. Making that appropriate diagnosis is important for multiple reasons, but it's important for considering treatment implications. People who have diabetes related to pancreatitis are much more likely to go on to need insulin therapy, for example, than patients who have routine, typical type 2 diabetes. So I talked a little bit about this, but if you look at patients with chronic pancreatitis, the estimated lifetime risk for diabetes is anywhere between 25 to 75%. It kind of depends on the population you're looking at. So what the study population is, what's causing their disease, how long they've had disease. So it really varies a little bit by the study you look at, but the bottom line is it's high. We know that people with chronic pancreatitis are at very high risk. What we maybe know a little bit less about is the risk in acute pancreatitis. We used to think that acute pancreatitis was just inflammation of the pancreas that then completely resolved, and unless you had necrosis or dying pancreas tissue clearly on imaging during the episode, you recovered and your pancreas functioned as it should. But that turns out probably not to be true. If we look at studies published to date, it seems that as many as 15 to 23% of patients who have acute pancreatitis go on 2 to 3 years later to have diabetes. And if you include pre-diabetes, the risk is even higher. So it does appear that this is also a risk factor. So why do people with either acute or chronic pancreatitis go on to get diabetes? Probably the top reason, especially for chronic pancreatitis, is that these individuals make less insulin. So, there's a lot of studies of patients with chronic pancreatitis where they do something like drink a glucose beverage or drink a meal beverage or get an IV medicine like an IV dextrose bolus. And we're able to demonstrate that way that people who have pancreatitis have reduced insulin secretion. And furthermore, if you look at pathology studies of the pancreas from people who have pancreatitis with or without diabetes, the number of beta cells making the insulin are clearly reduced. And there's also more inflammation present in those patients who have diabetes, particularly inflammatory markers. The other thing I'm not going to get into detail, but I think it's really relevant to a lot of patients who follow the National Pancreas Foundation is surgery. So some patients will have a partial resection or a total resection of their pancreas, and that's obviously, even with an islet autotransplant, associated with reduced insulin production. So reason number 2, and maybe less well appreciated until more recently, is that patients who get diabetes with pancreatitis may also be insulin resistant. There's some studies suggesting this, particularly insulin resistance in specific areas of the body, like the liver. And we do see that people who have obesity, which is associated with insulin resistance, have increased odds for pancreatitis related diabetes. And what we really don't know is whether other hormones might be contributing. So when someone has a malabsorption state, like chronic pancreatitis with exocrine insufficiency, some of the gut hormones that help the islets work might be dysfunctional or reduced. We also know that other islet hormone, pancreatic polypeptide, appears to be reduced in people who have diabetes related to chronic pancreatitis, which might be an important diagnostic marker, but it has been suggested that maybe this is possibly contributing to some of the insulin resistance. These are really areas that are still, I think, under study. And the good news is that the National Institute of Health has been very proactive in the past decade about research in that interaction between diabetes and pancreatitis. And there's now 2 very large multi-center study consortiums, the Consortium for the Study of Chronic Pancreatitis, Diabetes, and Pancreatic Cancer, and the Type 1 Diabetes Acute Pancreatitis Consortium, that each individually are running studies that are looking at chronic and acute pancreatitis and risk for diabetes. So lastly, before I wrap up here, there's the question of whether diabetes is different in children with pancreatitis. Well, there are fewer children who have diabetes with chronic or recurrent acute pancreatitis. It's only about 8% of the population. But I think it's important to remember that many of these children have hereditary pancreatitis, and that in and of itself carries a very high lifelong risk for diabetes, and they may be more likely to have surgery like TPIT. At least in our pediatric studies, more of these kids are on insulin who have chronic pancreatitis and diabetes, and a few of them clearly have type 1 diabetes. So we always have to consider type 1 in kids. So with that, I think I'll just briefly conclude here that this is a common problem. We lack some uniform terminology for type 3C diabetes, but certainly it's often under-recognized compared to type 1 and type 2. And insulin deficiency, and probably to some extent insulin resistance, may be at play in causing this disease. All right, so I'm going to stop my share and I'll turn it back over to Fred here.
Thank you, Melena. So I want to make a correction here. We're going to leave the questions and answers for the end. So now we're going to go to Dr. Mark Goodarzi's talk. He's a professor of medicine and director of the Division of Endocrinology, Diabetes, and Metabolism at Cedars-Sinai Medical Center in Los Angeles, California. He's a molecular geneticist and directs the endocrine genetics laboratory at Cedars-Sinai. He has over 26 years of experience in this field and has published numerous articles related to diabetes and metabolism, including in the context of chronic and acute pancreatitis.
Thank you, Fred. I just want to make sure, are you seeing those slides on the whole screen there?
Yes.
Okay, great. All right. So the objectives for today are to review the risk and risk factors for diabetes in people with pancreatitis. We'll talk about the symptoms of diabetes. We'll talk about how and how often to have screening for diabetes if you have pancreatic disease. And we'll finish with the health implications of diabetes in people with pancreatitis. So this is an analysis of 31 studies over 14,000 patients. And pooling the data from these 31 studies, they found that overall, the rate of new onset diabetes after acute pancreatitis was 23%, with a good amount of those treated with insulin. They then broke it down as far as within 5 years of the diagnosis, and then 20% had diabetes. Whereas if you look longer out, so 5 years away or longer from the acute pancreatitis, you see a higher rate of diabetes, 37%. So this is a concept we have here that the longer you go, your risk of diabetes may increase. In this analysis, they did identify a few risk factors for diabetes. So those who had severe acute pancreatitis versus mild, you see had a 40% rate of diabetes versus about 14% for mild. If there was necrosis during the acute pancreatitis, you see once again a higher risk of diabetes. If the pancreatitis was due to an alcoholic etiology versus gallstones or biliary, they saw a higher risk of diabetes. Age and gender were not risk factors for diabetes in this analysis. A separate study found that recurrent episodes of acute pancreatitis and smoking may also be risk factors for diabetes after acute pancreatitis. Talking about prospective studies, this is one of 152 patients who had acute pancreatitis who did not have diabetes at baseline. And they were evaluated 6, 12, 18, and 24 months out from their episode of acute pancreatitis. And you see in the table, for example, at 1 year, 7% had diabetes and 34% had prediabetes. And by 2 years, this had increased to 45% having prediabetes and 11% having diabetes. So clearly establishing acute pancreatitis as a risk factor for diabetes. What this study went on to do was to actually do an analysis to look at the trajectories of people's sugar levels. And 3 groups were identified. In the blue here, which was about 32% of the group, their sugar levels were normal and stayed normal over the 2 years. So these are the luckiest individuals. Then in green here was a group of people whose sugar levels were around the pre-diabetic neighborhood, but stayed stable over the 2 years. So also pretty good prognosis. And that was actually 60% of the cohort. However, about 8% of these patients you see had a very drastic increase in their glucose levels over time. And these are the ones that are really high risk of developing diabetes. Unfortunately, this study wasn't able to identify risk factors that we could use to identify these people at the highest risk. And that might be related to the size of the study, 152. And so this is partially the basis of the DREAM study that you heard from a second ago from Dr. Bellin. It's a multi-center NIH-sponsored studies. There's 10 centers across the country. And our goal is to enroll 800 patients to give us a much clearer picture of what's going on and what we can do to predict diabetes here. And we're looking for people with acute pancreatitis within 90 days. I put the website of the study here in case you're interested in learning more or even participating. Please visit this website. Switching over to diabetes after after chronic pancreatitis. Here it's very clear that the longer you have chronic pancreatitis, the risk of diabetes goes up. So this puts together a few studies. So at diagnosis of chronic pancreatitis, 4 to 10% already have diabetes. 1 year out, that goes to 7 to 10%. 10 years after having chronic pancreatitis, 30 to 50%. And by 2 decades or more, the majority of patients will develop diabetes. Here's another sort of pooled analysis of 15 studies of over 9,000 patients. And overall, the rate of diabetes and chronic pancreatitis was 30%. But you see, once again, the duration makes a difference. And in fact, in the study, the main risk factor for diabetes was how long you had chronic pancreatitis. Now we're going to get a little more granular into individual studies that looked at multiple risk factors. So here's an analysis of over 1,000 patients with chronic pancreatitis, and they looked at multiple risk factors here and found several that were associated with diabetes, the most dramatic being obesity and exocrine insufficiency, meaning the digestive function of the pancreas not working well. And it's really dramatically illustrated here. So if you've got the gray bars here represent the people who have the digestive insufficiency. And we can see here going from underweight, normal, overweight, and obese, certainly the risk of diabetes increases, but when you layer exocrine insufficiency on top of that, it's really quite severe. So for example, if we look at the group of people who have normal weight and no exocrine insufficiency, only 19% of them had diabetes. But if you look at the people who were obese and had exocrine insufficiency, 57% of them had diabetes. Here's another study that we did, looking at 645 people with chronic pancreatitis, and you see 43% of them had diabetes. And we found that both traditional risk factors for type 2 diabetes, shown in yellow here, such as age, weight, being male, not being white, or smoking, were risk factors for diabetes and chronic pancreatitis, as well as pancreas-specific factors, such as like complicated acute pancreatitis, or exocrine dysfunction, or calcifications of the pancreas, or atrophy or shrinkage of the pancreas. Interestingly, in this analysis, an alcoholic cause of the pancreatitis actually had lower rates of diabetes. And when we focus on people who had their diabetes before the pancreatitis, you see that the yellow factors or the diabetes factors predominate, whereas when we focus on people who had their diabetes after pancreatitis, the more pancreas-specific factors predominated. Moving on to screening for diabetes. This is a table from the American Diabetes Association as far as their screening recommendations for the general population. And what they recommend is people who are overweight or obese and have an additional risk factor should be screened for diabetes. So that includes a family history of diabetes, a high-risk race or ethnic group. Essentially, if you're not a non-Hispanic European origin individual, you are at higher risk group. History of cardiovascular disease, high blood pressure, low levels of the good cholesterol or HDL, or high levels of triglyceride or fat in the blood. Individuals with polycystic ovary syndrome, physically inactive, or other insulin resistance traits should be screened. People with prediabetes, as you just heard was defined a second ago, should be tested yearly. Now, if you've got, and also women who've had gestational diabetes during their pregnancy should be tested every 3 years. So if someone doesn't have any of those risk factors, just a completely healthy individual, no symptoms, they recommend screening at age 35. And if the tests are normal, repeat screening every 3 years. Those are the recommendations for adults. For children, screening should start at puberty or when they're 10 years old or whatever's earlier. And it's pretty similar. Basically, for the children who weigh more and have additional risk factors, such as their mother had diabetes or gestational diabetes while the child was pregnant, that's a risk factor for diabetes. Family history again, race, ethnicity again, and any signs of insulin resistance or insulin-resistant conditions. So what we noticed right away is that the American Diabetes Association doesn't provide us guidance as far as screening individuals with pancreatic disease for diabetes. Now, I think it's fair to say annual screening is warranted. That's what's recommended for people with prediabetes, and we know that these individuals are at high risk. The same tests that you just heard Dr. Bellin describe for making the diagnosis of diabetes are also used for screening, just summarized here again. And as she mentioned, we can nicely rule out type 1 diabetes because we can measure certain antibodies. But there are no specific tests today to distinguish type 3C from type 2. And studies have found that up to 90% of people with type 3C diabetes end up being classified as type 2 diabetes. And I'm going to show you why that's a problem in the next few slides. Now, remember, this annual screening is a recommendation for someone who's asymptomatic. If someone has symptoms, which I'll describe in the next slide, and has a history of pancreatic disease, they should be screened for diabetes right away. So what are these symptoms? Now, the symptoms are related to high levels of glucose. The word diabetes or conditions of diabetes essentially refer to high levels of glucose or sugar in the bloodstream. And when your sugar levels are greater than around 180, sugar starts spilling out in the urine. The kidneys aren't able to hold on to such high levels of sugar. And when you have sugar coming out in your urine, that actually pulls water with it as well. And that leads to the classic symptoms of diabetes. So polyuria, which refers to excessive urination, and that includes nocturia, having to wake up at night 4 or 5 times to urinate because all that sugar and fluid is coming out from the bladder and out in the urine. And so, as a result of having to urinate all day long, people with diabetes have polydipsia or excessive thirst, thirsty all day long and have to drink water all day long. And then there's this polyphagia or excessive hunger. There's a lot of calories being lost by the sugar coming out in the urine, and that leads to hunger. And of course, that also leads to weakness and unexplained weight loss. So these are the classic symptoms of diabetes of any cause. There are other symptoms that may occur. People may have blurry vision. That'll often correct once their sugar levels are corrected. And if someone has very low levels of insulin, they may actually present with diabetic ketoacidosis, which is a very dangerous condition. Patients may lose consciousness, have high levels of acid in their blood. It's one of our diabetic emergencies. So now we're going to talk about the health implications of type 3C diabetes for the rest of the talk today. And we're going to take a journey around the world. The flags of the various countries where these studies were done are in the corner of each slide. So this was a landmark study that looked at across the entire United Kingdom, identifying new cases of diabetes in adults. And so ultimately it came to 559 with type 3C diabetes, and they were compared to 30,000 plus with type 2 diabetes. And what they saw was that people with type 3C compared to type 2 had higher blood sugar levels, and they needed insulin treatment sooner and more frequently. So for example, at 5 years, only 4% of the new cases of type 2 needed insulin. People with diabetes after acute pancreatitis, 21% of them needed insulin 5 years later. And diabetes after chronic pancreatitis, 42% needed insulin only 5 years after the diagnosis. So really points to the issue of these patients should not be misdiagnosed as type 2 because they need much closer monitoring. And they may need to transition to insulin more quickly. In terms of health implications and the complications of diabetes, the things we worry about when people have chronically high blood sugar, we worry about their eyes, their kidneys, and their nerves. This study compared over 150,000 Korean individuals with type 2 diabetes to 3,600 with pancreatic diabetes. And I guess the good news was the risk of diabetic eye disease, or also called retinopathy, was similar. However, the nerve damage and the kidney damage was about 40% more likely in people with pancreatic diabetes. Another health implication of type 3C diabetes is low blood sugar, also known as hypoglycemia. This study from Denmark looked at a large number of people with type 2 diabetes, and actually for pretty large number, considering the studies that have been done with diabetes after acute pancreatitis and diabetes after chronic pancreatitis, several thousand. And what they define here as severe low blood sugar, that's a low blood sugar episode that required hospitalization, quite severe. So for the type 2 diabetes group, 3 per 1,000 person years. So let me explain what person years means. So this basically means that if you've got 1,000 people with type 2 diabetes, in 1 year, 3 of them needed to go to the hospital for hypoglycemia. For diabetes after acute pancreatitis, that was 17 per 1,000. And for diabetes after chronic pancreatitis, 49 per 1,000. So you see, chronic diabetes associated with chronic pancreatitis is more serious than diabetes after acute. Here's another way of looking at it. Over the entire course of follow-up, nearly 20 years, only 6% of those with type 2 diabetes had to go to the hospital for low blood sugar. That goes up to 17% of people with diabetes after acute pancreatitis, so more than double the rate. And people with diabetes after chronic pancreatitis, a third of them had to go to the hospital because of a low blood sugar. So really pointing out the difficulty in controlling diabetes in these people. What about hospitalization for other reasons? So this study from New Zealand, she looked at in the database covering the entire country for hospital discharge data. They collected 959 people with post-pancreatitis diabetes and compared them to 10 times more people with type 2. And they found for post-pancreatitis diabetes, there were higher rates of hospitalization for chronic lung disease, kidney disease, and infections. However, there was no difference in hospitalization for heart attack or stroke. The same study went on to look at survival. So comparing people with type 2 diabetes to type 3C, in a 1 year period, 80 of 1,000 people with type 3C died. compared to 66 of 1,000 people with type 2. So that's 14 more people per 1,000 people with type 3C diabetes dying compared to type 2. And this shows it graphically. So we have type 2 on the left, post-pancreatitis diabetes on the right. And we see that the most common cause of death is cardiovascular, which is true for all of us. It's the most common cause of death in Western societies. And that was the same between the two groups. What explained the 14 more people per 1,000 dying was cancer. Deaths were higher in post-pancreatitis diabetes, as well as GI causes, gastrointestinal causes, and infections. So there was no difference in cardiovascular, respiratory, or kidney-related deaths. In this study from Taiwan, they looked at a large number of people with diabetes or without diabetes, looking for the risk of pancreatic cancer. So you see a very large number of people studied here. And the bottom line, for people with diabetes and chronic pancreatitis, the risk of pancreatic cancer was 0.34%. So that doesn't sound very high, and it's not. Pancreatic cancer, thankfully, is rare. However, let's get into the details here. So people who had no diabetes and no pancreatitis, only 1 per 10,000 people was diagnosed with pancreatic cancer in 1 year. So that's going to be our baseline here. People who have diabetes but no pancreatitis, that risk was 1.8. So what that translates to is additional cases compared to no diabetes per 100,000 people. That's 8 more cases per 100,000 people compared to non-diabetic. If you look at chronic pancreatitis, you see that the risk is much more severely increased than having just diabetes. So now we have 19 people per 10,000 per year getting a pancreatic cancer. And that translates to 184 additional individuals compared to non-diabetic. And now when you have people with diabetes and chronic pancreatitis, 33 per 10,000 develop pancreatic cancer, which means in excess compared to non-diabetic of 325 cases per 100,000. So it's on a numerical level, it's not a huge number, but it's significant. And pancreatic cancer is a very serious type of cancer. So this is something we really worry about in this field. So just to summarize what we've gone through here today, we talked about the risk for diabetes in people with pancreatitis. And in general, it's about 23% after acute pancreatitis and 30% after chronic, but really, especially for chronic, increases with duration. So after several decades, this figure is going to be over 50%. Risk factors for diabetes in people with pancreatitis are a mixture of type 2 diabetes risk factors like age, smoking, family history of diabetes, obesity, but pancreas-related factors also play a role. The digestive insufficiency, calcifications in the pancreas, or shrinkage of the pancreas. We talked about how and how often to have screening tests, and the most convenient are fasting glucose and hemoglobin A1C. And I, as an expert, have recommended annual screening. There are no official guidelines, but I think that's a good place to start in people who are asymptomatic. Screen right away if there are symptoms of diabetes, and those would be the excessive urination, being thirsty all day, being hungry all day, weakness, weight loss, blurry vision. You can also see fatigue, nausea, vomiting, and diabetic ketoacidosis. And this is a very serious form of diabetes that we need to distinguish from type 2, because compared to type 2, we see poor diabetes control, greater need for insulin, much higher risk of low sugar reactions. We see increased diabetes complications, increased hospitalizations for various causes, decreased survival, and a small but significantly increased risk of pancreatic cancer. And that's all I have.
Thank you, Mark. That's an excellent talk. So now our next speaker is Dr. Brooke Palmer. Dr. Brooke Palmer is a licensed clinical health psychologist with the University of Minnesota Medical School and an assistant professor of medicine at that institution. She supports patients in coping with the emotional and behavioral impacts of living with acute and chronic health conditions. One of our main clinical areas of focus is working with patients living with chronic digestive issues and disorders of gut-brain interaction. She also does research and teaching within the medical school. Brooke?
Thank you very much. And it's not just me that's going to join us now, but June and Mark and Crosley as well. If you want to turn on your cameras and unmute yourselves, we have some patients that are going to speak with us about their experiences with pancreatitis and diabetes. And I think first, maybe we can just have our patient representatives introduce themselves, their name, and where they're from.
My name is June Strayer.
Go ahead, June.
Go ahead.
I'll pick. How about we'll let June go first.
Sorry.
Mhm.
Okay, sorry. My name is June Strayer. I live in Northeast Indiana. I was diagnosed with acute pancreatitis back in February 2012. And it's believed I have type 2 autoimmune pancreatitis. And I'm also diabetic on an insulin pump right out of the gate from 2012.
I'm Crosley.
I'm Crosley's father, Mark. We're both from Cincinnati, Ohio. We both had PRSS1 chronic pancreatitis. We both had pancreatectomies and islet cell transplant surgeries, and we're both on varying forms of insulin.
Thank you. Well, maybe we can start out with some easy questions, kind of summarizing your pancreatitis story. You kind of talked about your diagnosis, and I know, June, you mentioned kind of getting on the insulin pump right off the bat or being diagnosed right off the bat. So we'd be curious to hear about pancreatitis story and when you were first diagnosed with diabetes. And maybe we'll start with Mark and Crosley.
Yeah. So Crosley and I both started having pancreatitis at a young age. Crosley had TPIT surgery 2 years ago, and then as a result of that has been on insulin and on an insulin pump since. I had a TPIT surgery many years ago in 1998, and I actually was on insulin injections for a short while after my surgery, but then in my adolescent and early adult years, I wasn't on any insulin at all. And then more recently required some need for insulin, and I've been taking Lantus, which is a long-acting insulin, and that's all that's needed or has been needed by me to help manage my stuff. So,
June?
As I said, I had the acute attack in February of 2012, and when I came around enough that I could realize what was going on, I noticed they were giving me insulin in the hospital. And so when I was discharged, I said, well, why was I taking insulin in the hospital? And do I need, what is this about? I went home, when I first went home from hospital, my doctor unfortunately went on holidays the next day after I was discharged. So I went out and bought myself a glucometer and checked my blood sugar and thought, I don't think it's supposed to be this high. And a week later, one of his associates put me on long-acting and short-acting insulin injections. And I did those up until about 5 years ago when I went on an insulin pump. And thank goodness for those and for Dexcom. They saved my life.
Great. Well, let's hear about what resources have you all found to be the most helpful, and maybe we can think about with some of the initial learning curves when you were first trying to figure things out. You've already alluded to a little bit, but things that we might want to share with the audience as well.
The first thing I did was I went online and I started researching everything I could find about diabetes, about insulin, about how to use it. I stuck to the main hospitals, like I was going to the Mayo Clinic or Johns Hopkins. I Googled support groups and got into chronic pancreatitis groups online through Facebook. And really that was that and my family doctor were my main support as far as knowledge. But I will say that the more you know, the better off you are. So really make education your friend with this, because you need it, because it's your life you're talking about, and things can change so much within a day that you need to have a good backup. You need to have that solid foundation of what exactly is wrong with you.
Yeah, and I can speak on sort of behalf with Crosley's diabetes management. From the gate, we really seeked a lot of support from groups that supported type 1 diabetics, because that seemed to be what was most similar to what his needs and stuff were. Crosley went on the insulin pump, and he's on the insulin pump currently still. And a lot of our things too, with learning that, going from, you know, no prior management of glucose control, a big part of that was like nutritional things. So like learning apps like the Calorie King in places where we can research carbohydrates and things like that. We learned a lot of those different things though from the type 1 diabetes support groups, like where we can go to sort of get those information and fill in our gaps of knowledge. So I'd say that's probably been one of the more helpful things for us is finding those groups.
Great. What do you think some of the initial struggles that you faced? You know, you alluded to some of that with where to even get information, but then, you know, compared to what are your daily or weekly struggles now? How has that changed, or how have you kind of adapted?
I'll speak again, sort of just on Crosley's behalf. You know, he is about to be a 10-year-old young child, and so he wants to do many of those things that 10-year-olds are doing. And so a lot of our current struggles are just trying to make sure we kind of foster a lifestyle for him that's as normal of a childhood as he possibly can. And so, you know, it's not as easy sending, you know, your kid off to a sleepover who's, you know, a diabetic, who's on insulin and has these things to monitor, but, you know, we've found workarounds. We've done really well with it. And he's had to grow up, you know, a lot and mature in a lot of ways to manage his own stuff. And so I think that's another thing is like when I speak on behalf of our, you know, the pediatric population and stuff, a lot of these kids kind of get forced into a lot of responsibility at a really young age. And so I think, you know, trying to be a parent and taking that stressors off the kid, but also trying to teach them responsibility and finding that balance is a really fragile place to be. But
it's a good way to say it. Any thoughts, June?
I know when I was first diagnosed, it was very overwhelming. It seemed like all you did was check your blood sugar and take diabetes and try and figure out carbs. And the first month I cried a lot. At that time I was using a glucometer. So I was checking my blood sugar 7 times a day is what my doctor told me. And it was just like, you think your life is over. And I mean, I know it doesn't seem significant now looking back, but then it was life altering. So one of the biggest challenges is being consistent and not getting overwhelmed. I think more currently, as my disease has progressed, I guessing, I find that my blood sugars, even though I have a Dexcom and I'm using a T-Slim pump now, my blood sugars are erratic. And so it's trying to figure out what you can and what you can't do and how to adjust your pump to make it work. And there are days that you just get sick of the whole thing and you just want to take your pump off and throw it across the room, but that never works out. But it's a real learning curve. You have to adjust as you go because it's not going to be the same as day one. It's not going to be the same as it was 5 years ago. It's not going to be the same as it was a month ago. So you just really have to be diligent and keep asking. If you run into trouble or you get frustrated or you feel like you're burnt out, make sure you tell your endocrinologist or your diabetes educator so that they can help you out of it and get over that point, because it is frustrating sometimes.
Full-time job.
Definitely.
Crosley and Mark, how have you had to explain to teachers or anyone working with Crosley about what he needs to take care of his diabetes?
So my teachers let me carry my phone on me so we can monitor my blood sugar, and then the nurse has like juice boxes, so whenever I go low they will just call the teachers, and then the teachers tell me to go down to the nurse, and then I can check my blood sugar and then do what I need.
Does that work pretty well?
Yeah.
Good. Yeah. Any other tips? What about like for sports? You said you were coming back from baseball tonight.
Yeah, so he's again very matured through the process. He does have to, have a go bag that has all of his things that he needs in it, whether he's going to go low and need carbohydrates. He needs his phone in close proximity because he is on a continuous glucose monitor, and just to help us keep track of those things. And then, as mentioned before, when he's going somewhere and he's sort of outside of our eye, there's always sort of a rundown with people that explains to him his situation, what he has that's working to control his diabetes, what he has to help us monitor him, and just letting them know and giving them that cushion and space to do what he might need to do, whether it's correct himself or taking some extra carbs and whatnot. And so there is an extra layer all the time of just kind of having to communicate what his needs are, but we've sort of really got that process ironed out to the time it's needed to. So
Great. I'm going to ask at least one more question, but maybe we'll have time for two. So this one's just about how can loved ones help for people with diabetes? How can they help support them?
I can answer that. My husband is my number one hero and supporter. He would recognize when my blood sugar went low before I did, before the days that I had a pump. And so I was always unaware of what was going on. And it never crossed my mind that my blood sugar was dropping. So I take him whenever I go to any education events. I took him with me for a week long of what to eat when you're diabetic. It helps if they can try not to criticize you or say, well, I don't know, you can't have that. Can you have that? But to try and make it seem that your life is as normal as possible. It helps to have someone else give you a kick in the pants every once in a while, but also to remember if you go on a trip or something, all the things that you need to take with you. And because it becomes so second nature for us, for me, I don't think I just hop in the car, and I've noticed I'm not as diligent as keeping snacks in the car as I used to be. And it's good to have someone cover your back. I've taught him how to fill my pump, how to put it on if he had to. Not that he ever has, but it's good to have that kind of support. For sure.
How about you, Crosley and Mark? How have people been supportive of diabetes management, or how can people help their loved ones?
I think June hit it. I think, not one of the nice things is just having support that's not treating him different or like he's, adverse to not able to do things like a normal kid. So he appreciates going to parties. He appreciates a bite of birthday cake, all those different things, but it's just having, a support would be just some general knowledge or background of kind of what he needs to function. Maybe if he is at a friend's house or something, just knowing like let's not just go overboard with the sugars tonight because it's going to put him in a bad situation later on. So just, you know, giving him, like I said, some freedom to still be a kid, but also just having some restrictions and reserve at the same time with that. I think those kind of things go a long way. You know, he just wants to be like everyone else. So helping us to facilitate, that's what we appreciate most from him.
Yeah, great. Thank you. Well, I think we can wrap it up here because I'm sure there's people in the audience that might have questions for our patient panelists, but also the doctors too. So
Thank you, Brooke. Let's see. Okay, my video is back now. Okay, thank you, Brooke. So now let's start with our questions and answer segment. There are several excellent questions that have been posted in the Q&A. And I'd like to start with the question for Dr. Bellin. One of the patients asked, why is total pancreatectomy with islet autotransplantation favored over a pancreas transplant?
Yeah, thank you for that question. We get this a lot, particularly with people who are coming in thinking about surgery. So we didn't talk a lot about TPIT, but for anyone who's maybe in the audience who isn't as familiar, that as you heard is the surgery where we take the pancreas out, isolate the islets, and transplant them back. And so when we're doing that and people come in for evaluation, sometimes they'll ask, if you're going to take the pancreas out, why can't you give me a new one, right? Why can't we just do a pancreas transplant with that? Which is a really logical question to ask. But with the islet auto transplant, we're actually giving people back their own islets, just trying to keep what they have, and they don't need any special medicines like anti-rejection medicines to keep those islets. But if we were to take a pancreas from another person, like a deceased donor, kind of like we do with a kidney transplant, and give that to the person who has their pancreas out, unfortunately, then you need a lot of medicines that slow down the immune system and suppress the immune system from rejecting that new organ. And that actually carries a lot of its own risks with it in terms of risk of infection and other side effects from the medications. So actually for most people, especially if they get the islet auto transplant, managing diabetes, and even with all the potential complications of diabetes, is more manageable and safer health-wise than getting a full organ pancreas transplant and dealing with the potential complications and the immunosuppression that comes from that. So that's why that's not a very common thing to do a pancreas transplant for someone who has a pancreatectomy, because usually doing the islet auto transplant and managing the diabetes is actually a healthier and safer thing to do.
Thank you, Melena. Mark, a question for you. One of the patients asked a very good question. Is there a beginning and an end to chronic pancreatitis?
Which Mark?
That would be
That's you, yeah.
So it is a chronic condition. So, and as Dr. Bellin alluded to, it's not, you know, as far as the beginning, in the early phases, it's sometimes very difficult to make that diagnosis. So sometimes, you know, someone may have chronic pancreatitis, but the diagnosis is not made in a timely fashion, just because there are various criteria that have to be met, imaging, etc. So sometimes the beginning is a little fuzzy, but once it starts, in most people, it is a progressive condition. So things can get worse over time. It depends. Some people will deteriorate, you know, more quickly than others. But as far as an end, typically, you know, that would be unusual for it to somehow resolve. It's a destructive process. The scarring and inflammation in the pancreas typically gets worse over time. So I wish I could say we had a cure, that we could say there's an end to it. Of course, TPIT is a type of end because you've removed the pancreas. But short of surgical procedures, we don't have any medications that we could use to cure chronic pancreatitis. I hope that answers the question.
So there's a related question here. I have chronic pancreatitis from a pancreas division. Does this change any factors for type 3C diabetes? I think the question is asking, does this change the risk for diabetes if you have a pancreas division and chronic pancreatitis?
Yeah, that's a good question. Most studies have not specifically distinguished that type of chronic pancreatitis from chronic pancreatitis in general. So I think the best assumption at this point would be that the risk is similar. I don't see any biological reason why to propose that chronic pancreatitis for that particular cause would have more or less risk than more general chronic pancreatitis.
Question for Melena. Does TPI, so that's total pancreatectomy with islet autotransplantation, does that reduce complications associated with diabetes?
So we think if you compared that to total pancreatectomy alone without islets, because we know that people with the islet transplant part generally have better glycemic control, lower A1C levels that are closer to the normal range, that should reduce the risk, at least of some of the diabetes complications long-term. Now, I will say that with the caveat that there aren't really head-to-head comparisons right now of people who have the total pancreatectomy and a total pancreatectomy with islet autotransplant. And really no comparisons either between TPIT diabetes and just sort of routine chronic pancreatitis diabetes. So that's our best knowledge that we have, but I don't have a complete answer to that question.
Okay, thank you, Melena. Mark, Mark Goodarzi, question for you. What do you do as an endocrinologist to treat type 3C diabetes when sugars are so erratic? And what advice would you give to someone like a pancreatologist who sees a lot of chronic pancreatitis patients with diabetes? I think we lost your video connection.
Yeah, it looks like Mark is frozen, huh?
Yeah.
Well,
maybe I'll switch to another question and we can come back to this. So Melena, we have another question here about TPIT, so islet autotransplantation. Could you explain why the spleen must be removed?
Yeah, I can, and it has nothing to do with the diabetes. Actually, it's not removed by 100% of surgeons, but our surgeons here do always remove the spleen. And it has to do with the vasculature and the fact that the splenic vein is essentially also taken out with the pancreas, and the splenic vein is sort of the main vein draining the spleen. And so there was a time way back when the surgeons here would look at the spleen and see if it seemed to be draining okay from other collateral sources, other vessels, and if it did, they'd leave it in. And if it didn't look good, they take it out. The problem is that we had some patients who had very major bleeding events, patients who had to go back to emergency surgery for massive spleen enlargement, and some patients who developed some gastric varices later. And so it really just has to do with the anatomy and the vasculature that it's usually taken out now. And of course, that has its own little risk in terms of infection, and we want to make sure people get splenectomy immunizations, get prompt attention for fever, but that's the rationale behind that.
Mark, I think your connection has been restored now.
Yes, I'm back. Sorry about that. Right when you were asking the question, I
lost. Did you get the full question?
No. Could you
let me do it again then. What do you do as an endocrinologist to treat type 3C diabetes when sugars are so erratic? And what advice would you give to someone like a pancreatologist who sees a lot of chronic pancreatitis patients with diabetes?
Yeah, so diabetes in general can be very difficult to treat, especially when there's insulin deficiency, and this form can be especially difficult. So I think having a continuous glucose monitor is essential, so we can see what's happening, 24 hours a day with the sugar levels. And correlating that with, activity and diet, we often need to give, frequent adjustments of their insulin, and it's very difficult. We just can't achieve perfect control of the diabetes. We want to avoid hypoglycemia because that's very dangerous. But we also don't want to let their sugars run too high, because then we have to worry about the nerves, the kidneys, and the getting damaged. So it's a difficult balancing act. It really depends case by case. Some people early on actually are fairly straightforward, and sometimes we can use oral medications like metformin. But in more advanced cases, it becomes extremely challenging. And engaging with a pancreas specialist is very helpful, because if there's significant dysfunction of the digestive part of the pancreas, that makes it all the harder to control diabetes. So if, getting the enzyme replacement as needed, and that's something that, a pancreas specialist can help with, giving the right dose of enzymes, that can help us with the diabetes control, because now they can actually absorb the food that's being eaten. But it does depend case by case, but it's a lot of work. It's a lot of work. Close monitoring, frequent contact.
So there are now 3 questions here that have a common theme. So I think I'm going to lump them together and ask Melena if you could address, because one of the questions is pediatric related. So the first question is a patient with chronic pancreatitis and pre-diabetes inching closer to diabetes. What can be done to slow down the process, including perhaps diet? The second question is 16-year-old daughter was recently diagnosed with chronic pancreatitis. Is there anything that can be done to prevent progression to diabetes? And the third one is a patient with autoimmune type 1 pancreatitis, pancreas division, and exocrine insufficiency. What can be done to reduce the risk of getting diabetes? So I think these are all related.
Yeah, so this is a really excellent question, and I wish I had a better answer, because we don't really know how to halt the disease process and the scarring per se to prevent that fibrotic injury and islet injury and prevent diabetes. So we need better answers on the pancreatitis side. We certainly know that if someone is obese, if they're more insulin resistant, that might be something that pushes them a little bit more over the edge. So I do think that, there's probably an important role if you're trying to reduce your risk of maintaining a healthy body weight, staying physically active, doing kind of all those conventional things that people would think of as being healthy and reducing diabetes risk. And the place where we're really lacking is on how we kind of stop the chronic pancreatitis side of things, and how do we reduce that damage. I think the autoimmunity is a little bit different, the type 1 diabetes risk. I don't think we understand that as well. We certainly see some people who have pancreatitis and type 1 diabetes, but we really with type 1 diabetes in general don't have great ways to prevent that in terms of what you can do in your life. But fortunately, I think that risk is fairly small. That's just something we think of in some of these patients where we see diabetes diagnosed in the setting of pancreatitis, but it's not, I would not say it's a common risk.
And I think Melena would add to that, if someone has chronic pancreatitis and you know what the injury, the cause of the injury is, and if it's removable, for example, alcohol.
That's very good.
Right?
That's a very good point.
If someone is drinking, then you don't want to drink, because that's going to add further injury to the pancreas.
I got to get on my pediatric brain, but yes, you're absolutely right.
Yeah, in children that's not an issue, but in adults we see that
too. We have some data in our patient population that suggested maybe a little bit more rapid C-peptide response in people we've tested with mixed meals with smoking. So yeah, reducing things that cause injury like alcohol and smoking are important.
Exactly. So this was a terrific program tonight. I would like to thank all the panelists tonight. Dr. Bellin, Dr. Goodarzi, Dr. Palmer, Dr. Anderson, and the leadership of the NPF for putting this together, and also announce that this is just the first of a series that we're having this year. So stay tuned for the next webinars that will come out at different times this year. I don't know if Subcal wants to say anything about those dates yet, but these are in preparation at the moment.
Thanks, Dr. Toledo. We don't have dates set yet, but we do want your help. And if you have any subjects that you want us to discuss, I know nutrition is a hot topic, so we'll definitely cover that with diabetes, because pancreatitis and nutrition is already hard enough, but then when you throw in diabetes, that's, you know, it's a hard mix, but we'll cover that. But if there's anything else, let us know. You'll be receiving an email with the YouTube link to rewatch this if you want. And I'm going to talk to the speakers to see if they can share their presentations as well, because that was a popular question. And also, thank you so much, Mark and Crosley and June, for sharing your story, and Brooke for doing the Q&A as well. And we really appreciate everyone's time. We're 1 minute over, but thank you so much, everyone, for your time and support tonight.
Thank
It
you.
was a pleasure.
Thanks.
Thank you.